I would like to call chairperson for the next session, Dr. Rajesh Deshmane, Dr. Vinayak Harare, and Dr. Nilima Mane.
So, thank you. So, Dr. Eugene Braunwald, who is known as a father of modern cardiology, he says that the time has come for cardiologists to learn more about diabetes and for diabetologists to learn more about cardiology. And perhaps it is now appropriate to establish a new specialty, that is diabetocardiology, whose practitioners become the front troops in the war against new modern disease. So with this introduction, I would like to invite Dr. Hiremath sir, Dr. Shirish Hiremath sir, for his presentation.
Good evening. I'm used to talking to a cardiology crowd with some bit of diabetes, but today I'm talking to all diabetes and little bit of cardiology. So I'm a little bit uncomfortable as I start, but let's see what happens when you have ACS and a patient to be managed subsequently following ACS. So ACS has a big range from unstable angina to ST elevation myocardial infarction. All depends on whether the thrombus is completely occluding the vessel or partially occluding the vessel. But ACS means thrombus, so it's on top of cholesterol or minimal cholesterol. So this is how it is. You have occluding thrombus, which gives you an ST elevation or a QAMI. Then partial is the non-ST elevation. And unstable angina could be a critical narrowing, but when same stable patient becomes a little bit unstable, there's always some component of thrombus. So over years, there have been treatment changes, especially in angioplasty. It was treated as conservative treatment initially, and then go for an invasive study. But then most of it now is changed to an early invasive strategy. We are basically going to concentrate on antiplatelets in this particular area. And for a long time, you can see clopidogrel ruled, maybe a couple of decades, till it got pushed out to some extent with the newer two molecules, the prasugrel and the ticagrelor. In between came statins, like an event has happened, and subsequently you want to prevent another episode. We talk of high statins are bad, lowest is best. So this is what the current thinking is. And we all now agree that the LDL values, which were earlier recommended as less than 70, the European Society guidelines last year is recommending less than 55. The Lipid Association of India recommends less than 50 as the LDL value. So it is definitely less than 50, you can go down. And on this scale, we have PCSK9 inhibitors, which drop your LDL, and they are used pre-discharge for acute events. So ST elevation or non-ST elevation, ACS, they are discharged on PCSK9 inhibitors. Not all of them, of course. But what is important is once there has been an event, a prior MI, as you follow these, the possibility of getting a repeat event is very high compared to somebody who has had no event. So it is always very important to avoid one event. If you avoid one, you're probably avoiding many subsequent events. Now, this is also important to know that this is an Apollo Helicon study, which is was done in Sweden. And you have 1 in 5 in first 1 year coming back with an acute ACS. So once an ACS, next 1 year, will bring back about 25% of the patient. And this trend continues, though at a slightly lesser extent in subsequent 5 years. So once ACS, you have to do everything to prevent another ACS in these patients. So what ACS has done is sort of brought out this patient. The ACS event has shown that an event has happened and this patient is at a risk of something hidden inside. And that's why the non-culprit vessels can give you a recurrent MI. So once you fix the main vessel, a culprit vessel with an angioplasty, the repeat events are probably coming from the non-culprit vessels. And this number is probably bigger, the non-culprit compared to culprit in subsequent years. Like this patient was thrombolized. The LED shows a moderate lesion which was classed for medical treatment. Okay, he will remain asymptomatic from this lesion, but however, the non-culprit lesions like healthy looking today arteries can give you an event later. So when you want to give antiplatelets, you have to worry about ischemic risk on one side. Like every patient who has one ischemic event is likely to get another ischemic event, so ischemic possibility compared to bleeding risk. We would like to give antiplatelets for a long, long time, provided the patient has no excessive bleeding risk. On this scale, we have the antiplatelet agents. So the intravenous agents, we won't talk about it today because they are mostly in the cath lab use. But we have these irreversible agents. The classic is clopidogrel, and the newer one is prasugrel, while reversible one is Trichoglor, which is available. We did some intravenous cangrelor studies about 3-4 years back. This molecule is again very effective. It has a quick onset and a quick offset. So moment you finish your cath lab procedure, you stop the drip and the antiplatelet action is gone. So it's quite popular in US, but not so much in other part of the world. So when you put these three molecules together, clopidogrel, prasugrel, and ticagrelol, you find that direct acting is the tica, while others are indirect acting. They need to be converted. The tica is also reversible, and these two are irreversible. As you keep comparing, you realize that these two, the newer ones, have very rapid onset. So anybody who comes with ACS or an ST elevation, we like to give these two, especially the ticagrelor, because this molecule, prasugrel, is mostly a cath lab molecule when you want to use it for ACS. The platelet inhibition is very strong with these two, more than 80%, while the clopidogrel looks like a weak younger brother of these two. Tica has a very fast onset of action, while these are relatively slow. I would feel prasugrel is faster than clopidogrel. And you get non-responders to clopidogrel, while the two newer molecules do not have non-responders. Tica has a sort of disadvantage because adenosine reuptake inhibitor gets excited, and that's why some of these patients come with bronchospasm. Most of the time, we are using these molecules to prevent stent thrombus, as in this case. And on this front, the newer two molecules, the prasugrel and the ticagrelor, have run extremely well, and clopidogrel has got pushed back considerably. So the long-term risk of stent thrombosis after a PCI depends upon some procedural factors, some patient characteristics. So if ACS has been the reason for which PCI has been done, the chance of stent thrombosis is much higher than a stable case. And there are some pharmacologic factors like premature discontinuation, slow metabolizers, which can happen with clopidogrel. So the stents, many times we like to reduce the antiplatelet agents because we feel the newer stents are safer. And this biofreedom stent was actually recommended by the ESC as the only stent where you can have antiplatelet duration cut down to 3 months or sometimes even in 1 month. But to compete with this, we have many other studies, like this is one of them, Onyx 1, where another stent, the Onyx was used, and they found that it can match the biofreedom stent, which is actually a polymer-free stent. So we have to balance the efficacy of the molecule and the safety of the molecule. And for this reason, as we like to give more and more antiplatelet agents during the procedure, we like to do more radial procedures so that the groin doesn't bleed. Then minimize the DAPT duration. So you use advanced stent so that you can keep the duration quite short. And then use the lowest effective dose of aspirin. So most of you know that aspirin, when you are using with ticagrelol, the dose is only 75 milligram and not 150 or 300. So on one side, you have an ischemic benefit. On the other side, you have a bleeding risk. And as a smart physician, you have to balance out these. So if you have some renal function, the possibility of stent thrombosis is higher, while also the risk of bleeding is higher if you are especially anticoagulating the patient along with antiplatelets. So all these factors need to be balanced. Plato was the first study which highlighted the importance of ticagrelor. So this was a big study, and this compared the ticagrelor with clopidogrel. And clearly, the ticagrelor was considered superior. The same molecule in another study called Pegasus, which was done 1 year after the initial event with a reduced dose. So this was 90 milligram twice a day for first 1 year, and this was after 1 year at a reduced dose, 60 milligram twice a day. And in the first study, the Plato ACS, the ticagrelor was clearly superior to clopidogrel. So clopidogrel almost got completely replaced by ticagrelor in this kind of setting. Then came this Pegasus study. As I mentioned, the 2 dosages were used, 60 milligram twice and 90 milligram twice. So both had equal benefit, and they were clearly superior to placebo in this setting. Can we use ticagrelor after thrombolysis? The TREAT study provided the answer that in STEMI patient less than 75 years who initially received clopidogrel along with thrombolysis can be safely switched to tica in first 24 hours after fibrinolysis. So the answer is yes, you can switch to ticagrelor. Does it affect the mortality? This is the cure data where clopidogrel is used, and no significant benefit with clopidogrel aspirin was seen in preventing mortality in ACS in cure study. In Clarity also, no significant benefit with clopidogrel aspirin combination. The prasugrel in Triton-TIMI trial had again no significant reduction in the rate of CV deaths compared with clopidogrel. Prasugrel, of course, as you know, that it is contraindicated if your patient's age is over 75, weight is less than 60 kilo, and has a history of stroke, TIA, or some neuro event in preceding few months. Now compare these 2 molecules with ticagrelor, and you find that there is a 21% reduction rate in the CV deaths and 22% reduction in the all-cause mortality with ticagrelor compared with clopidogrel. So obviously, we would like to all give our patients a molecule like ticagrelor. The mortality benefit seen with ticagrelor is seen irrespective of this treatment strategy. Whether you do an angioplasty or whether you manage the patient with medical treatment, ticagrelor was superior to clopidogrel in all these subsets. In Pegasus, as I mentioned to you earlier, after 1 year, a smaller dose, 60 milligram was used twice a day. And here again, the Trichoglor was proved better than Prasugrel, as you can see here. So the benefit of Trichoglor 90 milligram in practical versus Clopidogrel showed consistency with Plato secondary endpoints in real world 12 months comparison. So this was a big study. The SWET heart, 45,000 odd patients. And what you saw earlier was actually a sort of randomized control studies, while this is a practical study which indicated a similar benefit that was seen in the randomized control study. You can see here the lower risk of death, MI, stroke, as well as death alone with Trichoglor compared to Clopidogrel. Now, similar study was also, result was also seen in Denmark registry, where a low risk of combined endpoints of myocardial infarction, ischemia, stroke, death were seen when you use Trichoglor compared to Clopidogrel. So these are all similar data. These are real-world outcomes, are similar to the randomized phase 3 trials. There were a couple of other studies, the topic and change DAPT studies, which had slightly different meaning, but as I mentioned to you, these had huge numbers, 45,000, 62,000, 18,000 in Plato compared to very small numbers in these two studies. So obviously I would trust the bigger data more convincingly. The Sheffield observational study similarly indicated that TICA was better than Clopidogrel under this setting. So what does ESC and ACS AHA guidelines talk about duration? As we saw, the initial 1 year stent thrombosis is very important, and we like to give them Trichoglor or Prasugrel. The longer you give, it is going to prevent them from getting into an ACS situation, because stent thrombosis generally does not happen after first year. So if you have a high bleeding risk possibility is not there, then the recommendation is go for 1 year, and you can try and go beyond this. So first 1 year, if there is no bleeding, the possibility of subsequent bleeding in next 3, 4, 5 years is quite low. And the Pegasus clearly indicates that there is a benefit in continuing beyond 1 year. If you have a high bleeding risk possibility, most of the time these are older patients, low weight, some kidney issues, and there you can stop at 6 months the dual antiplatelet therapy. So 12 months therapy may be considered in ACS patients who have tolerated DAPT without bleeding complications. So try and go beyond 12 months. That is the meaning, if your patient has no bleeding risk in the initial 1 year. Then people also talk of switching. I mean, many people feel that why give a risky drug for a long duration? And on this issue, when you switch from Clopidogrel to Trichoglor, this is the only outcome data available. In all other areas, you keep switching from Prasugrel to Clopidogrel or Trichoglor to Clopidogrel or between these two stronger molecules, but they have no outcome data. The outcome data is only here. So any patient who is on Clopidogrel, you lyse the patient, but you can switch them to Trichoglor and continue with them on Trichoglor as long as you want. So Trichoglor, irrespective of the pre-treatment and revascularization strategy. Now this is important, irrespective of the strategy. That means if your patient is going to say no to an angioplasty, if you're going to continue with medical treatment, even then Trichoglor is found to be useful. And when you want to switch from Clopidogrel to Trichoglor, you must always reload the patient. So if you lyse your patient just now, and you give 4 tablets of Clopidogrel as usual, and you want to switch to Trichoglor, reload the patient with 2 tablets as we normally do. So in the long-term risk of bleeding, you must remember, as I told you, patient characteristics are very important. Elderly patient, history of previous bleeding, low body weight. ACS bleeds, but also needs help in form of important drugs. Thrombocytopenia, this is what cardiologist generally doesn't like patient has dengue as well as is admitted for an ACS in the CCU. He would say, oh, I won't worry about platelet count, but it's very important to remember what drug to choose under these settings. So in general, if you have a high ischemic risk, try and push antiplatelets for a longer time, especially if your bleeding risk is low. So high ischemic risk and low bleeding possibility, try and go beyond 30 months. Then if on the other side, if you have low ischemic risk, like very few risk factors, only one event, and if you have a high bleeding risk, the antiplatelet could be stopped much earlier, something like 3 months. There are some other ways, like atrial fibrillation, patient is high risk for bleeding. We can use a device like this is the device which can occlude the left atrium, and your requirement for antiplatelet or anticoagulant can be kept down to minimum or even 0 in times. And this is where I would like to stop. Thank you for the invitation, and thank you for giving me time here.
Hello. We'll take few questions. Sir, I have one question. What is the role of aspirin in for the primary prevention in patients with diabetes or dyslipidemia?
Yeah,
And is there
actually,
any
yes, I think aspirin has gone through ups and downs, but the current thinking is probably no role. So if your patient is has got really multiple risk factors and you feel he's going to be very high risk case, very, very high risk individual, then maybe you can give it. But most of the recommendation is stop when the patient hits 70. So beyond 70, definitely, the bleeding possibilities clearly go up.
A role of GP2 inhibitor in unstable angina or non-stimulation MI?
Yes, I think there are many times patient presents to CCU. Let's say the CCU has no cath lab attached. So these are the patients who would get loading with antiplatelet. As we discussed, Trichoglor is safe because we don't know what the patient is going to do afterwards. He may agree to an angioplasty, he may not agree. Prasugrel has no data, so I would rather prefer giving Trichoglor. Give aspirin as you normally give, so these two are constant. You would always give low molecular weight heparin, and in some cases, especially when the angina is hot, TROP-T is positive, the tirofiban kind of medication, antiplatelet intravenous, has a definite role. So if your TROP-T is positive, I think there is a role for tirofiban, especially if you're going to shift the patient for a PCI.
In patients with ischemic heart disease, high-risk cardiac cases, and they also have some chronic thrombocytopenia, what will be the cutoff at which you will keep an antiplatelet and
50,000.
avoid?
50,000. If the platelet count is less than 50, no antiplatelets. I mean, if it is done as an acute procedure, yes, you have to give it. But again, keep your dosages down. Maybe use clopidogrel instead of using the stronger molecules.
Sir, in this era of diabetocardiologist, basically, how do you look this newer anti-diabetic molecule like SGLT2 inhibitors and GLP-1 analogs? And what have you tried this molecule? Because most of the time the case is referred to endocrinologist for further management. But so do you Are you using these medications right now?
Actually, I used to never write antidiabetics for years and years.
That's why,
It's
sir.
only now in last 2 or 3 years, I know who is the patient who should get SGLT2 inhibitors. So I generally write, please consider SGLT2 inhibitors, but I leave it to the
So you are also overweight the benefits of SGLT2 inhibitors
Yes,
and
abs-
GLP-1 analogs. Definitely, the
Yes.
benefits are.
Yeah, I mean, clearly there are lots of benefits, and if the diabetologist doesn't change, I phone them to find out why they are not changing. And sometimes I overrule them and change it, you know.
So,
Yes.
how do